Okay, great. So this is Dr. Jeff Klausner. I'd like to welcome everyone to our fourth GloCal career seminar. We've had a very successful year so far with a variety of different speakers who've shared their career trajectories, key decision points for them, their successes and challenges in navigating academia, public health, different government positions. And today we are extremely fortunate to be able to welcome Professor Craig Cohn, who without a doubt, without Craig, none of us would be here in this role today. And Craig has been really the stalwart for the GloCal program, the original founder of the program, 6 or more years, and really our leader and visionary in this training. So really looking forward to hearing from Dr. Cohn and his international perspectives on career, global health, research, being an academic, and it's going to be a wonderful session for us today. So thank you, Craig.
Thank you, Jeff, for that amazing welcome. I know if I ever get an award somewhere, I know whom I'm going to ask to usher me onto the stage. Anyhow, it's a pleasure to be presenting today. I really have a relatively brief presentation in regards to PowerPoint. I decided to keep it low on the PowerPoints for this presentation, for this discussion, which would allow us for more opportunities for discussion and to responding to questions or ideas that you have, because I'm really here to support you, the fellows, the GloCal fellows, in regards to your career, and using some of my stories perhaps for you to reflect upon, to conjure up various questions you might have. So I will get started. I also want to say, Jeff, the real visionary for the GloCal program is actually Kimberly Bale. We all wouldn't be here if it wasn't for Kimberly. So I just want to give another shout out to Kimberly, who's amazing at running and managing and the GloCal program on behalf of all of us. All right. I'm sharing my screen, and all right. So again, I put together just a few slides to highlight my career, to give you a sense of where I've come from. I don't know exactly where I'm going, so there'll be a future slide eventually. We could talk about that. Perhaps you have some advice for me for where I should be going. So I started, as you know, in the U.S., we split our undergraduate education and our medical education, unlike in most countries where since you come out of secondary school and you start university. Not to discount my university education, it was actually very formative for me when I was at UC Berkeley. I had many opportunities, not just within the university setting, but outside the university setting, to engage in a variety of extracurricular activities, which became very formative for me. For example, I volunteered every Tuesday evening for about 2 to 3 hours at the Berkeley Free Clinic to really get a sense of around equity, or the inequity of healthcare provision in our country and in most countries around the world. And the real need of, and the real opportunity to serve those, essentially the way that I was raised is to serve those who are of no fault of their own, or are less fortunate in some regards, especially in regards to being able to access healthcare and other sorts of social services. So I went to medical school in Kentucky. There's a story there which I won't go into, but essentially, well, very briefly, I worked in rural Kentucky in the mountains at the Cloverfort Clinic as a volunteer health educator. And it was there that I actually got to test some of my early ideas around service. I worked a lot in within the school system, within children elementary and secondary school in rural Kentucky. These are some of the poorest regions in our country, and this is in the mid 80s. There were still communities in rural Kentucky without running water, without electricity. So oftentimes when we think of the US, we think that those sorts of communities don't exist. Well, at least in the mid 80s, they did. It was also an area that 10 years prior, or 13 years prior, had just integrated education. So prior to the early 70s in rural Kentucky, where I was, the African American children went to one set of school or one school system, and the European American kids went to another school system. And you can imagine which school system was better resourced. So this is in my lifetime. This is in my lifetime, and it really was very formative for me, that time that I spent in Kentucky. Again, in medical school, this is before it's a very, mainly focused on my medical education at the University of Louisville. And I had the fortune to meet another Dr. Cohen, he may still be alive, I'm not sure, a pediatrician at Tulane University, and really, I think, started one of our country's first international rotations for medical students in the US. Tulane was really at the forefront, and it was really Dr. Cohen, this pediatrician, who had started working with folks in Latin America and the Caribbean. And I asked him if it was possible to, I met him at an AMSA, American Medical Student Association meeting, if it was possible for medical students from other universities to take part in the Tulane program. He said that it was, and I applied and ended up spending 6 weeks in Jamaica. And that was really my first opportunity to work internationally. Again, I was a fourth-year medical student, mainly providing clinical services, doing quite a bit of reading, and also, importantly, working with the community during that time. I did my residency in obstetrics and gynecology, very intense specialty as far as training is concerned, a number of hours required. And during my first year of residency, I was at the University of Washington and was fortunate to come in contact with people who later became my mentors in fellowship and really introduced me to the subspecialty, if you will, of reproductive infectious diseases. So a big focus on STIs that affect both obstetric and gynecologic patients, as well as HIV. This is now in 1990, 91. I then finished my residency at Northwestern University for 3 more years. And it was during that first year at the University of Washington that I decided I wanted to explore the possibilities of an academic career focused on research in women's reproductive infectious diseases. And I applied to work internationally, and I sent emails out to maybe 30 different researchers that I had come upon their names through reading the literature, and essentially all but one said no. I only had a 6-week elective, which is common in U.S. residency programs, and they said 6 weeks was too little time to get anything significant done, and sorry, can't do anything. But I was fortunate to be put in contact with a researcher who was at CDC, Ann Doerr, who's now at the University of Washington and Fred Hutchinson Cancer Research Institute. And she said, yeah, I'm starting this project with colleagues in Thailand and Chiang Mai. Might you be interested in working with us? And there was another professor, Kenrad Nelson at Johns Hopkins University, and Ann and Ken were partnering again with their colleagues from Chiang Mai. And I said, yeah, I'd be interested. So again, with no resources from Northwestern University, but essentially my own resources, I had several telephone calls and then ended up in my own dime, flying from Chicago, where I was, to Atlanta, spending a day with Anne, coming up with various ideas of research projects that I could potentially do during this period of time, during my third year of residency. And I also separately flew to Baltimore to meet with Ken Nelson to, again, further advance some ideas. They both were on board, and in the third year of my residency, I flew to Chiang Mai with some idea, a 4-page concept. This was in a different time when IRB submissions and the timeline that it takes to get ethical approval didn't take as long as it does, but it also was not as rigorous a process in order to protect human subjects. But I was able to essentially, with my concept, submitted for IRB approval, and within about a week, believe it or not, the Thai Ethical Review Committee approved my protocol. And with very few resources except for mainly myself and I had 2 people that I was working with within the STI clinic in Chiang Mai. I was able, over the 6-week period, to enroll 144 women, which became the basis of, you see the title of the paper that ended up being published. Now, this work ended up being the first of its kind to actually demonstrate an association between bacterial vaginosis in women and HIV seroprevalence. 40% of the women young women that were seen who identified as commercial sex workers who were enrolled were living with HIV, and BV was more prevalent in this group, about 3.5-fold more prevalent than it was in the HIV uninfected commercial sex workers. So it was based on a hunch, and that's maybe my first lesson, is that sometimes, as those of us who are clinicians or those of us who work with clinicians, we see things, maybe not every day, but we encounter patients, or we hear about patients or conditions where it stumps us. We're not sure what the etiology is. We're not sure what the course is. We're not sure if there's an association. Why is this group of women or this group of men or children, whatever it is we're studying, why is this disease more common? This is essentially basic epidemiology, right? This was a cross-sectional study, very simple study. And I was also able to get, those of you who work in this field will see the name Sharon Hillier, who's at the University of Pittsburgh, and is really a leading researcher in regards to HIV prevention research around microbicides and PrEP and other preventative biomedical prevention, and leads one of the large NIH networks as well. I was able to get, because she used to be at the University of Washington, so again, through personal contact, which is oftentimes a benefit in advancing one's career, is meeting people, putting yourself out there, taking chances. And I convinced her to read the gram stains from the study that I conducted in Thailand. And she did it for free on her own time. She ended up getting authorship on this paper, some benefit. But of course, as a very junior scientist here, having somebody with the reputation of Sharon Hillier on this paper, along with Ken Nelson and Andur, obviously helps to highlight. Sometimes who you publish with helps to give greater light to your work, and that's especially earlier in one's career. It led me then to, while I was in Chiang Mai and I was taking care of these women living with HIV, this is obviously pre-ART era, I decided to commit myself to a career to helping these women and preventing HIV, preventing BV, and so forth. I then applied to an ID fellowship, which is very unusual for an OBGYN. And I had known, because I'd spent some time at the University of Washington that first year of my residency training, that about every 3 or 4 years, they took an OBGYN to the ID fellowship program. So I applied and was selected. And when I was selected, I was paired with a project that needed an OBGYN to work in Nairobi. And I was open to the idea, although I previously had seen myself working in Asia because of my time in Thailand, but and I really knew very little about Africa. I had not had the opportunity to travel anywhere within the continent previously. I was very naive, but I was open to the opportunities, mainly based on the opportunities to work scientifically, but obviously became very important to me personally as well. So again, after residency, 3 weeks after finishing working 110 hours a week, those of you who've done residency know what I'm talking about. I was in Seattle, and then I was there for 3 weeks for an orientation for the fellowship. And 3 weeks after finishing residency in Chicago, I moved to Nairobi. The University of Washington had a long-standing and has a long-standing collaboration with the University of Nairobi, dating back to the mid-'80s. And so I was based there from initially I went for 15 months, but after being there for only about 3 months, I was enjoying the work so much, and also my personal life. For the first time, I had actually most weekends for personal time spent with friends, to do other activities that I enjoy, especially in the outdoors. Kenya is just a wonderful country with amazing people, amazing land. So I asked if I could stay for a full 2 years, and my mentor at that time said sure. And I ended up spending most of the next 8 years there, and I'll mention how that happened. So again, I was sent there to look initially at the effect of HIV infection in women with a condition called pelvic inflammatory disease. At that time, there had been very little research done on that topic. They designed already a study that would be conducted among women who had inpatient PID or women who had more moderate to severe disease. That study got expanded to both an inpatient study, but also we were able to conduct an outpatient study as well with people with less severe PID, which is more common. And this is one of the reasons why I was applied for the GloCal for the GloCal grant, or the grant that became GloCal, is because I really believe, for those of us in the U.S., and I know we have many of the fellows you're in your country where you're from working, but for those of us coming from the U.S., I really believe in the value of as much time as one can possibly do to spend time in country, wherever it is you're planning on working. And so that's one thing that gravitated me to apply for GloCal, is that there was this requirement of a 1 year in residence for the U.S. trainees. And I think even 1 year is short, and I ended up spending almost 8 years of my life living in Kenya, and another 8 months later on with my family in Kisumu. That was another phase of my career, later phase of my career. And during that time, I was able to, and I still rely on this information to some degree, I developed an understanding of the local health conditions and the local health system. I was living in it. I was working in it. I was working at Kenyatta National Hospital, the National Referral Hospital. I was working at the University of Nairobi. I was teaching the residents and the students. I made personal connections with these individuals as well as professional. I was doing surgery within the hospital, teaching surgery, laparoscopy. And going through, and those of us who've worked in the medical system in Kenya or similar settings know there are significant challenges. The suction may not be working today. The power goes out, and if you're operating, that's not a good thing. You can't find the anesthetist. Now, we have some of these same problems, not electricity, at least in the US, but we have some similar problems in the US system as well. So it also has helped me to work within my own healthcare system in the US, but certainly understanding the challenges helps me to understand what are the gaps and what are some potential solutions to help to improve people's health. And most importantly, I developed partnerships. Many of you know Professor Elizabeth Bakusi, who's my professional partner on this work in Kenya. And essentially, for those first 2 years I spent in country, I only left once for 3 weeks to attend my brother's wedding. I needed somebody an OBGYN to help keep the project going while I was away. And through another professional contact, somebody said, well, they knew this recent graduate of the residency program, University of Nairobi, Elizabeth Bakusi. Why don't you go try to find her? I think she's over in Kemry. And I went over to what I thought was her office, knocked on her door, and she was in. And she took up the opportunity to work with me for those 3 weeks. Those 3 weeks extended now into essentially 25 years. So the importance of partnerships for those of us coming from the U.S., for those of us who are from whether you're Kenyan or Peruvian or wherever, those partnerships that you establish that may start out over a simple issue, trying to work together on a project, or somebody comes to you with a question. Some of those relationships may grow and may become lifelong or nearly lifelong partnerships and relationships. And I would say that out of this, at least from my perspective, if it wasn't for having met Elizabeth Bakusi and having developed this partnership and relationship over all these years, that I don't know, I would not be doing what I'm doing now in regards to Kenya, perhaps not in regards to training as well. So take chances, reach out to people you don't know. And you never really, all sorts of things may happen, all sorts of potential. So, and during that time, during this early phase in Kenya, earlier phase, I started to build a research team again. After Elizabeth returned from the University of Washington after completing her MPH, she and I together developed a research team, and the other person who's now a leading researcher was my first mentee, is some of you might know Nellie Mugo, who's now at Kemry, was at the University of Nairobi prior, another OBGYN, a leading researcher in PrEP and cervical cancer prevention and so forth. And together we started hiring staff, because you need staff to run these projects. In the beginning, I was the clinician, the researcher, the data manager. I was a statistician, a very poor one, because I had not received any formal training in statistics until I did my MPH. And also I was the administrator. So once a month I'd go to the bank and get money to pay people and buy things. So that another lesson there is that I now have the aptitude, that I understand what, at least at a base, I was even the driver, part-time driver, so I understand the challenges. These are many of the people that make up various research teams, depending what sort of research you're doing. And I have an understanding of what it takes to do a job, what are the challenges, and what it takes to do the job well. And then I have a predilection for training the next generation. That's one of the reasons why I'm in academic global health or academic medicine. Both U.S. trainees and especially junior researchers from Kenya, where most of my work has and continues to take place. And so it was during that time that I started to focus on training the next generation, again through establishing a relationship with Elizabeth, and then eventually with Nellie, Christina Mochari, Fidel Sinduba. These are many leading figures around global health research in Kenya, where at one time or another, either we were working together or my mentees. I would say I was their mentee as much as they were mine. We learned together. So after 2002, I decided to repatriate to the U.S. Main reason was I felt like I needed to reconnect with my U.S. institution, which at the time was the University of Washington. I would spend about 10 months of the year. I then transitioned to junior faculty while I was at the University of Washington after my first 3 years of fellowship. And then I would spend 10 months of the year in Kenya, home, and 2 months during the summertime doing clinical work back in Seattle. but I felt like I needed to reverse that to some degree. And so at that time I was married, and my wife and I decided to move to the US, where we spent a year. I then moved to the mid-faculty phase. This is a period of movement and significant growth in regards to my career and to the program that I co-lead with Elizabeth. While I was moving to Seattle, I was being recruited to move to UCSF. Obviously, both institutions have fantastic reputations for the type of work that I do. The main reason to move to San Francisco was mainly personal. This was just before my wife and I had children, and I'm actually from San Francisco. So after 18 years of wandering around the country, wandering to Kenya, Kentucky, Chicago, Seattle, I essentially got to come home just before my wife and I had children. And in addition, and sometimes movement creates opportunity, I essentially was able to skip the assistant professor phase and move straight into associate. So essentially I got recruited in as an associate professor and skipped the assistant professor rank, which I would have had to go through at University of Washington. So that was good news. And also at this time, Elizabeth and I decided, for a variety of reasons, which I'll mention briefly, that we decided to move the geographic location of our research from what had been Nairobi and some of the informal settlements around Nairobi to Kisumu and regions around Lake Victoria. The main reasons for that were twofold. One was need. Those of you who are aware of the HIV epidemic in Kenya know that the region hardest hit by HIV is in the Nyanza region around Lake Victoria. And there's a whole variety of reasons why that's the case. And number one, and then so there was a need around HIV prevention as well as care and treatment. And number two is there was just more room in regards to being a researcher. Nairobi just seemed crowded with researchers from University of Nairobi, Kenyatta National Hospital, Kemri, as well as the collaborations with the University of Washington and University of Manitoba, Ghent, on and on and on, Liverpool. Many different organizations were focused in Nairobi, which represents about 10% of the population. So we decided to move, and we had the opportunity to do that, to Kisumu. And this became, there was an opportunity to apply. This is early PEPFAR days, 2004. And literally, there was an RFP where CDC wanted to get US academic institutions and Kenyan academic institutions engaged in HIV care and treatment. As you know, PEPFAR primarily supports program implementation. And they thought there'd be a value to having academic institutions engage in implementation, especially in regards to being able to test and advance innovation, which there was obviously back in the early days of PEPFAR, huge need, and there's still a huge need to work towards more efficient and more effective programs. So I essentially used my summer holiday. Everybody was at the AIDS conference in Bangkok or on holiday, literally, and wrote what became the proposal for FACES, which is Family AIDS Care and Education Services, which is a PEPFAR implementing partner supported by CDC now in our 12th year. And that HIV care and treatment prevention program has become the foundation for many, many, many clinical and implementation science research projects, program evaluations, as well as, importantly, training for Kenyan trainees, students, doctors, nurses, pharmacists, epidemiologists, etc., as well as those from the US, a high proportion of those from UCSF, but also from other institutions in the US and in Canada as well. And actually, we just recently had a trainee come from China. So people are coming from, I guess we're getting some notoriety, some positive notoriety in regards to our training opportunities. So this is also a period, where I brought on many fellows, started mentoring many fellows, both in Kenya and UCSF, with this idea that the weight of the entire collaboration from UCSF's perspective was on my shoulders. And I saw there would be a huge value if the program could grow, not through me holding up more and more on my shoulders, but if other individuals with other disciplinary practices and specialization could be brought into the program, which is essentially what we did on UCSF very successfully with epidemiologists, sociologists, anthropologists, pediatricians, dermatologists, neurologists, people who specialize in later years in agriculturalists, economists, health economists, and many other folks as well. One of the challenges during this phase, and I'll get into this more in the later phase, is around training the next generation of Kenyan scientists and retention. Elizabeth and I have not done as well in that way, and I'll mention this a little bit as I get into the next phase. And maybe since some of you are in that phase, have some suggestions and be helpful for me. So this is the later faculty phase. I would say maybe the last 7 years or so. As I mentioned, FACES has grown tremendously. We were responsible for part of 3 counties. We're now responsible for Kisumu County, which is one of the high burden counties in Kenya. Last year, we performed somewhere around over 800,000 HIV counseling and testing, about 50,000 voluntary male medical circumcisions. We have about 60,000 patients who are on HIV care and treatment, on ART, and about 30,000 women getting prevention of mother-to-child transmission care and treatment services as well. So it's a very large program, and it supports about 20 global health implementation clinical research studies. The budget is somewhere around 18 million a year as a portfolio. About 12 million of that, maybe about 11.5 million of that is FACES. And then there's a real focus during this phase, as I mentioned earlier, on leading training and mentoring programs. So you're a beneficiary of that mission, my own personal mission, but the mission also of all the other faculty and staff Kimberly had mentioned to support GloCal. The Reproductive Infectious Disease Program, we had 11 fellows move to that program. It's currently not funded. And then Mentorship Initiative, which I won't get into right now, but essentially working with leaders from around the world to advance this concept of mentorship, which is really such an essential ingredient when it comes to professional development and professional to promotion. And how can we, the larger we leaders, how can we inculcate cultures of mentorship within LMIC institutions? And even, I shouldn't say even, within US institutions, it's not ubiquitous. UCSF is quite advanced with having mentorship inculcated throughout various departments and within its schools and within the university, although there are still gaps. But in regards to at least many of the institutions in low and middle income countries I visited, there's such a huge gap and such large opportunity. But what's needed from my perspective is to actually inculcate a culture within the institution, which then will support individual mentor-mentee relationships and mentorship teams. But if we can change the culture at an institution, we can have a greater impact than just training one person to be an excellent mentor. And then for the past 2 years, I've been the co-director of the UC Global Health Institute, which again is the host institution for GloCal. It's a 10-campus-wide entity with partners around 10 campus of the UC system with partners around the world, and a mission around research and training and also advocacy and policy. I should just, so one of our challenges I'll mention during this later phase, and it also, I mentioned it earlier, is being able to train and then retain junior and mid-career Kenyan scientists within our program. Elizabeth and I have trained, I won't even come up with the number, but a huge number of Kenyan researchers. I should say, I look at it as a success, almost all of whom are working in Kenya in some capacity or another, either at an academic institution or for an NGO or international NGO, working in the area of HIV and reproductive health and really making a difference. We've, within our setting, the way that we've usually been able to retain US trainees is supporting them in submission of a K grant. I think many of you know what that is, the NIH Career Development Awards, which supports 4 to 5 years of training, covers most of one's salary as a junior faculty member, as well as money to conduct your research. It's only been the last 2 years that those awards now are available for international scientists as well. It's called the K43. I think you've heard about that already. I've spoken about it at the orientation that we were all at in July. It's something to look at if you're from one of our partner countries or institutions as an option. It is obviously very competitive. But with your training and with good mentorship, I'm sure you have a good likelihood of being successful. But that's one of our problems, is that people go away for training or stay in Kenya for training, or both. They had a role. Oftentimes we've trained people who've been clinician administrators within our program. They go to the University of Washington or UC Berkeley for training. They come back. They don't have their job anymore. Now they want to do research. And we don't have funding necessarily to support their position. And that's been a real challenge for us that we have yet to overcome, at least successfully. So it leads to some imbalance in our program in Kenya, to something Elizabeth and I speak about often between the U.S. scientist and our Kenyan scientists. And it also puts an inordinate strain on the relatively few Kenyan scientists that are within our program. If you take a look at 20 studies, you can imagine, ideally there'd be 10 to 20 PIs in Kenya who would be collaborating or leading these studies. And that's unfortunately not been the case. So still have a challenge. You notice I didn't put late faculty phase, I put later faculty phase. So I'll have to add another slide, hopefully one with some additional successes. And I just wanted to, I became kind of interested in this when I met with Roger Glass in January, looking at, this is called bibliometrics, a field I never even knew existed, but essentially demonstrates the associations between institutions by looking at where the authors reside in which institutions. And as you can, this is looking at Kenya. This is publications from 1980, I believe, onward to 2016. You see, the Kenya institutions are in yellow. The U.S. institutions are in, not sure what color that is. It's not orange, but whatever color it is. And then the other the non-U.S., non-Kenya institutions are in gray. And you can see that the two big institutions in regards to biomedical research or global health research are University of Nairobi and KEMRI, Kenya Medical Research Institute. And looking at the U.S. institutions, you see University of Washington. The size of the circle means how many publications we're looking at in regards to the co-authors. The U.S. Centers for Disease Control, Fred Hutchinson Cancer Research Center. So these two really go together. Here's UCSF up here, and most of that would be the work that Elizabeth and I have done with connections. You see considerable connections still at the University of Washington. That represents essentially where Elizabeth and I have come from, and Elizabeth remains affiliated with the University of Washington as well as with UCSF. And you also see, though, that there are some institutions that are islands that are not well connected in So there could be opportunity for greater collaboration. I think there is actually within Kenya, in order to bring people together from various disciplines, different ways of thinking. Also helps to consolidate resources to help science go forward. And I can say that the work, not just that I've done, but the work that's been done in Kenya has really made a huge impact in so many areas around STIs and HIV in particular, but also reproductive health, in moving, not just moving health forward and bending the needle, improving healthcare to Kenyans, but also helping people around the world. Okay. So now it's the discussion time. If people want to, you can send me a chat message. Maybe you have, no, you can send me a chat message, or you could go off mute and ask a question. Is anybody there?
Yes, yeah. Hello.
Catherine, it's really.
Yeah, I just wanted to say I liked the last slide. It's kind of sums up the big thing, how you are going down across countries. So I'm still thinking on the.
Sorry, Catherine, you're going in and out. Perhaps I would suggest if you want to ask a question, perhaps you could type it into the chat part. I see you like the last slide. Okay.
Yeah, so what I wanted to ask is that amount of collaboration and networking that is displayed in the last slide. I kind of didn't really understand how did you get to network that much and create partnerships all around those places. Thank you.
So, Catherine, it's really difficult to hear you. Perhaps you could, if you don't mind, could you just type your question? It was something about partnerships.
Okay, I'm gonna type now.
Yeah, that's great. Does somebody else have a question while Catherine's typing hers?
Hi, Craig.
Hi.
Yeah, thanks for the wonderful talk. I just want to ask, do you still have research team in Kenya, and where are you based right now?
Yeah, so no, it's not me, my research team. It's Elizabeth, it's our research team, it's collaboration research team. And yeah, there's a very large program. So FACES is in our 12th year. And then there is, again, these 20 research projects that are going on. I'm the PI of some of them, maybe 2 or 3. And then people that have previously were our, and I say our fellows, meaning Elizabeth and my fellows, many of whom now are not at UCSF. They're at other U.S. institutions, UAB, UC Denver, University of Michigan, on and on and on. That these individuals spend part of their year in Kenya with their partners. Sometimes they're working with Elizabeth Bakusi directly, sometimes with other researchers at Kemery as co-PIs. And so the whole program is probably around, I don't know, somewhere around 1,500 people or so is the team. Many of those people are research assistants and peer educators and counselors and those sorts of people in the clinical program. But there's also large research teams as well. I should also say there's a transition for the program maybe about 10 years ago, maybe 8 to 10 years ago. There's not a full-time expatriate working in Kenya. The work in Kenya is led by our team in Kenya, with relatively, depending on the project, frequent or less frequent visits by the team at UCSF and the other U.S. institutions. Did I answer your question, Benga?
Yeah, thank you very much.
Yeah.
All right.
So the last slide is not published. That was part of a presentation. It gets complicated, but it was part of a presentation that Roger Glass had. I would have to ask his permission if I could share it, which I'm willing to do. In addition, I believe that there is a website where you can create these slides on your own, putting in whatever, if you work in Tanzania, you could put in Tanzania, and you could come up with your own criteria for how you want to create these figures. So it's something that I believe is available for free on the internet. Let me just
Hey, Craig.
Yeah.
Hey, Craig, I have a question. This is Jeff. So obviously, thank you for that wonderful story with obviously a happy ending. But there was a period in there of, it seems like 8 years, when you were either a clinical instructor or a senior clinical fellow living in Nairobi, having University of Washington affiliation, but you weren't a faculty member. What was going on then in your head in terms of career and the challenges you were facing? That's a pretty prolonged period to be in that gray zone.
Yeah, I was a assistant. What was I? I even forget what I was. Assistant research professor or something like that, which is essentially a not very high rank of academic position. The University of Washington is odd in that way, at least when I've looked at other institutions as well, is that they have a lot, they obviously have a world-renowned infectious disease training program, of which you are also a graduate of. And some people decide to stay, most people decide to leave and have their careers outside the University of Washington. For those who stay, and I was one of those early on, and I saw myself staying in Seattle for my career, it was normative. So I wasn't worried about it because I wasn't alone. Grace John Stewart, Hal Martin, these are people who are my generation. We were essentially the first 3 fellows from the University of Washington to be in Kenya. I think Grace and Hal were first and second, and then I was third. And we were in a similar situation. So there were some other issues I should mention coming from, and this is, I know I see Michael's on the line. Coming from a surgical specialty, there's additional challenges than coming from a medical specialty. So I think more so with the surgical specialties, if you don't practice medicine, you do lose skills. So for example, now I'm not practicing in the hospital. So then and I haven't done surgery now for about 8 years. The point is that my departmental chair in OBGYN was much less used to having people like me spend majority of the year out of the country, where the Department of Medicine and Pediatrics there was greater precedent, if you will. So I wasn't that worried about my position per se, although it did cause me, I had to negotiate with my chair and my division chief, and eventually, hold on one second. Elin. Sorry, I'm reading this call. It doesn't work. Really does not work. Sorry, I'm at home and there was some noise at home. So I had to negotiate, and having the other offer from from UCSF helped me negotiate a counter offer at the University of Washington, but they couldn't match the offer at UCSF, and especially for the family reasons, my wife and I decided to move. So sometimes there is a help.
Thanks, man. Bye, my maka. Bye.
I hear more family noise. Sounds. So I think sometimes it is important to look for that other offer, even if you want to stay, but there is a negotiation. It gives you a negotiation, some leverage, although you have to be a little bit careful that you don't burn bridges. And I didn't. Especially for the first 5 years after I left the University of Washington, a high proportion of my scientific collaboration remained with my colleagues at the University of Washington. It took me longer to build new bridges at UCSF to build the network here. Let me just look at that question that Catherine had. Yeah, I'm just looking at Catherine. So again, there wasn't a slide that I created. It was Roger Glass, actually somebody working for Roger Glass at the Fogarty. I believe I can try to find the link, and I can see if I can send it out. But I believe there's a website where you can actually create these sorts of bibliometric graphs, if you will. Okay, so I think I answered Catherine's question, and seems like a lot of people were interested in that figure. Other questions?
Hi, Dr. Cohen.
Yeah,
thank you for the great talk. This is Noah. I was wondering, once you got over to UCSF, what's the best way to kind of start networking when you're kind of in a mid-level position and figuring out who to collaborate with at that stage? Thank you.
Yeah, maybe I'll tell a very brief story as well. So I was recruited mainly by Nancy Padian, who's not at UCSF now, she's at UC Berkeley now, an epidemiologist. So she had been at that time a real leading figure around women and HIV, and had started a center within a center, if you will, or a program within the center called Women's Global Health Imperative. So I was the most senior faculty member within her group, and she helped to connect me, as well as my division chief helped to connect me within the HIV sphere here. Now, different than the University of Washington, which had a very centralized program on HIV, essentially everything kind of coming up. If those of you who know who King Holmes is, University of Washington, a mentor of mine and of Jeff's and many other people, probably well over 100 people. He would be the connector. He would know what was going on with various programs, and the various programs within the University of Washington sphere worked together around HIV and women's health. At UCSF, essentially we ended up with several different, I would call it fiefdoms, and I really came in and saying, look, we can do much better together. And even as a mid-career faculty member, I was able to help. I won't say I'm responsible for the entire change at UCSF, but help to change the way that we do business, so that whether you're in CFAR, the Center for AIDS Research, or whether you're in the HIV division, whether you're in the Bixby Center in OBGYN, where I'm at, that we can do much better working together to address the pressing issues around HIV research. So I was able to make those connections. Eventually, after being at UCSF for 3 years, Nancy Padian left. And that's something else to pay attention to, that sometimes when somebody above you, senior to you, leaves, of course, it's disconcerting. But it also has the possibility to create opportunity. So I became in many regards, the go-to person around women and HIV, not for all aspects of women and HIV, but for many of the aspects of women and HIV, I was brought into leadership positions within CFAR, within the AIDS Research Institute, within the Institute for Global Health Sciences, and so forth at UCSF, in part because somebody senior to me left, creating space. So that's something that, not that I wished for her to go, I actually had wished that she would have stayed, but sometimes when that happens, it creates opportunity. Let's see, I have another question. Cementing what Michael says, how do you balance clinical research and family? Yeah, so everybody has to make decisions around their own. I think that I probably worked hardest during my, well, definitely residency, but aside from residency, I probably worked hardest during my junior and phase, and then also my first 3 or 4 years of being here at UCSF. That's why I needed to build a program. I came in with funding, but I did not have much funding. I essentially support 90% of my salary plus most of the salary of about 20 other people here now. At that time, it was much less, but I needed to create salary for myself and to have a study coordinator and an assistant at the least at UCSF, plus a team in Kenya. So I wrote a bunch of grants, and those of you who've been, obviously, I think all of you have been writing grants. It's a tremendous amount of work, teamwork, and long, long hours. That was before I had children, and when my kids were very small. I was able to take long times off, and I still do during the summer. My wife is from Sweden, so we spend considerable times in summer in Sweden with our family there. And so I was able to work hard during most of the year and then take time off during the summer. I still do that. But actually, I don't work as many hours now. I try not to work most weekends right now. I try not to work most evenings either. Now the team is bigger, and I think my role is more of a convener, more of a leadership role. And so and I also look at grants and running projects more as a team effort than when you're junior, when everything rests on your shoulders. And then as far as clinical, especially as a surgical specialty, I've had to, over the years, first thing I did was give up inpatient GYN. Just wasn't operating enough. Then a year and a half ago, I gave up inpatient OB, which means no call. And that means more time with my family. So about 2 to 3 nights more per week, I'm with my family. And I used to spend that time at the hospital. So again, there's a time for everything. Figuring out the right balance for you, it's what's important. Talking with your partner, and being able to be in a position where you can make changes. What's that about the K? So the K award, there's something called a K43, which is a mentored scientist career development award through the Fogarty, and it is now offered. The K43, you can look that up on the Fogarty website, is for junior scientists from low and middle income countries, where previously folks from outside of the U.S. who didn't have a permanent resident or a citizen of the U.S. could not apply for a K award. So I'm going to have to go. I have another call starting in 1 minute that I need to join. If you have other questions, you feel free to send me an email, and I'll respond as able. I'll try to find that link for the website to create those nice images around the bibliometrics, and send that out to you. And it's something you can play with if you're interested.
All right. Well, thank you so much, Dr. Cohn. That was a wonderful inspiration, and we'll give you a warm GloCal fellow. Thank you. Good luck, and take care. Bye-bye.
All right. Thanks.
Thank
Thanks,
you very
everybody.
much.
Take care, everyone.
All right. Thank you, Craig. Thank you, everyone.
Bye-bye.